So hello everyone, welcome back to my channel MedPaths with Piyush, and today we are going to start with a very important topic, that is endocrine pharmacology, and we are going to start with general introduction to anterior pituitary hormones as well as the growth hormone in depth. Talking about the anterior pituitary, it is also known as adenohypophysis that we study in physiology, and it's also known as the master endocrine gland. Although anterior and posterior pituitary both make up the master endocrine gland, but the most of the secretions or the most of the hormones released by pituitary are done by anterior pituitary. So the hormones that are released by anterior pituitary, they are peptide in nature, and this is an important point to understand because it will tell you about how these act on the receptors. As they're peptide in nature, they will act on extracellular receptors that are located at target cells. They will act extracellularly or on the membrane receptors, but they will not act intranuclearly or intracellularly. Coming to the hormones that are released by anterior pituitary, there is a mnemonic that will help you learn those hormones, that is flat pig. I've also mentioned it right here. F for FSH, L for LH, A for ACTH, T for TSH, PI for prolactin, and G for GH. If you doesn't know about the full forms, I'll once elaborate them. FSH is follicle stimulating hormone, LH is luteinizing hormone, ACTH is adrenocorticotropic hormone, TSH is thyroid stimulating hormone, and GH is growth hormone. So how they are released is very important. They are released by some cells. Adenohypophysis is made up of two types of cells. One is acidophilic cells and one are basophilic cells. So to learn which hormones are released by which part, I've made a mnemonic ALS. If you know, ALS is a disease, that is amyotrophic lateral sclerosis. So you can just remember ALS. So A for acidophilic cells, L for lactotropes. What do you understand by lactotropes is like something related to lactation. So prolactin is released by lactotropes. As for somatotropes, somatotropes is another name for growth hormone. So growth hormone is secreted by somatotropes. So these are the only two hormones that are secreted by acidophilic cells. All the rest of the hormones that we discussed in flat pig are released by basophilic cells. By thyrotropes, TSH, by corticotropes, ACTH, by gonadotropes, FSH and LH. Corticotropes also secrete two lipotropins and two MSH. MSH is melanocyte stimulating hormone. That is why we know when there is excessive production by corticotropes, there is also a skin darkening that is due to excessive production of melanin secretion. Okay. Out of these all hormones, majorly the growth hormone and gonadotropic hormones have therapeutic effects. Talking about TSH and ACTH, they have much more of a diagnostic relevance rather than therapeutic effects. So that was general introduction, right? So before we start with growth hormone, I would like to show you this. This is like, if this is a hypothalamus and this is your anterior pituitary. So these hormones are further released by some releasing hormones or inhibiting hormones inhibit them, so that are transmitted by a hypophyseal portal system. So here it shows that there is a portal system that connects hypothalamus to the pituitary. Okay, so now let's start with the main topic for today, that is the growth hormone. Firstly, we'll start with what are the physiologic functions that growth hormone performs. Now, growth hormone is required for normal growth and adult stature formation. How it does that is by inducing hyperplasia of bones. Right, it will cause hyperplasia of bones, that is increase in size and mass, proportionate increase, so that the bones grow. If there is an absence of gonadotropins, there will be no sexual maturation. Why I am talking about this point is because there is a difference between gonadotropins and growth hormone. If there is absence of gonadotropins, there is no sexual maturation. But if there is absence of growth hormone, there is still growth of brain and eye. This is an important point mentioned by K.D. Tripathi, that the growth of brain and eye is independent of growth hormone. Okay, now what is the effect on protein metabolism? Is a synthetic effect. Synthetic effect means synthesizing. Okay, so that means they will increase the uptake of amino acid into the tissues and there will be production of proteins. That means there will be a positive nitrogen balance. On fats, they promote utilization of fats. that is lipolysis. For glucose metabolism, there is very specific things to be learned, that the output of glucose from the liver is increased. That means the glucose formation from liver, that is the gluconeogenesis, glycogenolysis is increased, while the uptake of glucose by muscle is decreased. So ultimately both of them will lead to increase in the blood glucose levels. That is why growth hormone is sometimes very often referred to as the diabetogenic hormone. Here is a picture from Lippincott. This is just a small way for you to learn how to represent it in your exams. That there is hypothalamus, there is pituitary. You can just show by a flowchart the flat pic that we have already talked about: growth hormone, ACTH, TSH, FSH, LH, LH in males, females, and prolactin, and on the organs that they act. Okay, so please refer to this picture. It's an excellent picture to draw for your exams. Now coming to how growth hormone acts is by JAK-STAT pathway. Growth hormone acts via JAK-STAT protein kinase pathway. I will not go into that much depth. It's just like growth hormone will come here, bind to this receptor, that will ultimately lead to some conformational changes, forming a ternary complex that will ultimately lead to the metabolic effects produced by growth hormone. Okay, so coming on how the growth hormone functions are produced. They can be produced either directly or indirectly. First, let's talk about indirectly. What this indirectly means is that they are through some peptides called as somatomedins or insulin-like growth factors 1 and 2. IGF is insulin-like growth factors. The main source of formation of IGF-1 is liver. Please remember this point, that the main IGF that regulates whole of the growth hormone, indirect effects is by formation by liver. Other sites also produce IGF-1 like kidney, viscera, muscles, fat or bones, but that other site production, they act locally. And what is this manner of hormone action called? That when they are released, they are acting locally. That is known as paracrine manner. So here you can see in this diagram, kidney, viscera, muscles, fat or bones, they are producing IGF-1, which is not going to bones or any soft tissue and making any effects of growth hormone. Rather, it is acting paracrine manner. While liver, which is the main source of IGF-1, this IGF-1 is acting on soft tissue as well as bones. So that is how it acts indirectly. Okay. What you need to understand about insulin-like growth factors is what effects it will produce. So IGF-1 will produce effects like insulin, because we are saying that it's an insulin-like growth factor, right? So what it will promote is it will promote lipogenesis. Now there is a confusion. Here we told that there is lipolysis. So you need to understand that growth hormone is acting in two contradictory ways. Majorly it produces lipolysis, which we will talk about right now. But how insulin-like growth factor is acting, that is to be understood. It will promote lipogenesis and it will promote glucose uptake by muscle. That is, both are contradictory to what we have already studied. If it is acting like insulin, it should not be called as diabetogenic hormone. But it is called diabetogenic hormone because of its direct effects. So now let's come to that. What are the direct effects? It induces lipolysis in adipose tissue that we have just now discussed. It will increase gluconeogenesis, that will again increase blood glucose. It will increase glycogenolysis, that will again increase the blood glucose, and it will decrease the glucose utilization or uptake by muscles. Ultimately, all these three mechanisms will lead to increase in blood glucose, and these effects are opposite to those of what we just discussed, that is insulin and insulin-like growth factor 1. So because of these factors, what we understand is that growth hormone can accentuate metabolic derangements in diabetic people. So we should not give growth hormone in diabetic people if we have to come to a conclusion after all of this discussion. What accentuates mean is that like promotes or increases or makes a much more profound effect. Okay, so now let's come to regulation. I have already told you that hypothalamus will release some hormones via the hypophyseal portal system. So they can be GHRH or GHIH. GHRH is growth hormone releasing hormone, well, and GHIH is growth hormone inhibiting hormone, also known as somatostatin. These both are peptide in nature and they act via G protein coupled receptors via increase or decrease in CAMP respectively. So please understand that they are G protein coupled receptor. It can be very much asked as a question in MCQs or in general viva. So what are associated pathologies? Why do we need to understand about growth hormone? See, there can either be excessive production of growth hormone or there can be low secretion of growth hormone, that is hyposecretion. So if there is excessive production in childhood, that leads to gigantism, and if there is excessive production in adults, that leads to acromegaly. While in hyposecretion, there can be hyposecretion in childhood that would lead to pituitary dwarfism, and in adults it's very rare that there is hyposecretion of growth hormone, but if it occurs it will lead to lethargy or hyperlipidemia due to its lipid effects. Okay, so now coming to our major things that we have to use in exams that we should need to understand is uses. So to understand the use, firstly you need to understand an analog known as somatropin. See, we are talking about somatotropes. Somatotropes were releasing growth hormone. So growth hormone analog is known as somatropin. Please remember this name. It is a recombinant human growth hormone, also known as RHGH. So whenever you see RHGH, it means somatropin. And if it is a recombinant human, it will have low immunogenicity because we have extracted it from human itself. Okay, so where all can it be used? It can be used in 6 conditions which you have to learn, at least 3 or 4. Right, firstly pituitary dwarfism, that's pretty obvious. If there is dwarfism, we will give an analog. A Turner syndrome, that is characterized by 44 plus X, in which a female can be of low stature, so in that it can be helpful. Chronic renal insufficiency, it is a proven fact that when there is chronic renal insufficiency, it causes suboptimal growth, so that will be can get better by giving somatropin. Constitutional short stature children, that means idiopathically they are short stature, we don't know the cause of the short stature, so in that it can be helpful. Growth hormone deficiency in adults, which we just discussed, that it's kind of rare, but if it's there, somatropin can help. And the age related wasting. So these 6 points you need to understand. And what we can also understand is like the somatropin, how it is given. It is given as a subcutaneous injection. You can remember dose if you want, but majorly what you need to understand is that it is given subcutaneously, and preferably it's given in evening. These 2 points are the main points that you need to understand, that subcutaneous injection is given and is preferably given in evening. It can also be given intramuscular, but let's just leave it aside. Okay. So growth hormone is sometimes also used by athletes in sports, that gives them energy or makes them much more powerful or increases their height, etc. So it's banned in sports, so hence growth hormone is included in dope testing. And also it's thought to be anti-aging, but there is no conclusive research that is proves that yes it is anti-aging. It's just thought. Now we come to a very important topic. What are the adverse effects that you may need to write in exam? That can be a direct question, that write a short note on growth hormone. So we have already discussed that they have a low immunogenicity. Because why? Because we have already taught that it is produced from recombinant human growth hormone, somatropin. So there is a decreased chance of allergic reactions. Major adverse effects is there is pain at injection site. There is myalgia. Myalgia means there is muscle pain or ache. Lipodystrophy, this is due to lipolysis and lipogenetic effect of IGF-1 and direct effect of lipolysis. So there is some lipodystrophy. There is glucose intolerance, we have already discussed. They should be contraindicated in diabetic patients. Why? Because the direct effects, they lead to diabetogenic potential. So it should be contraindicated in people having diabetes and like obese people which are at a risk of type 2 diabetes mellitus, and headache, which is a general adverse effect. Okay, so that was about the analogs and their adverse effects. So now let's talk about what are the inhibitors of growth hormone. There are 4 that we are going to discuss. First is somatostatin. Please understand, somatostatin is not just inhibitor of growth hormone, it inhibits secretion of growth hormone, prolactin, thyroid stimulating hormone, all via anterior pituitary, insulin, and glucagon by pancreas and almost all of the GI secretions, all, which may cause steatorrhea, that is increased fat in stools, diarrhea, hypochlorhydria, that means less secretion of HCl, and dyspepsia, that is just abdominal pain. So it actually inhibits most of the hormonal secretions. Okay, but the main point that is very important is that it constricts splanchnic, hepatic and renal blood vessels. This constriction is very important because when it reduces the hepatic blood flow, because there is constriction of hepatic blood vessels, there will be a decreased GI and decreased hepatic blood flow, and it will ultimately lead to betterment of esophageal variceal bleeding. Where esophageal varices is a condition that is caused due to portal hypertension that leads to bleeding. But if you constrict the vessels, that bleeding will stop, right? You know from pathology that in stopping of bleeding, the first effect that comes is vasoconstriction. So that is how decreasing the GI and hepatic blood flow will control bleeding esophageal varices. But mostly now preferred drug is octreotide. We will discuss why it's preferred over somatostatin, but why somatostatin is less preferred is due to its short duration of action. And another very important point that you should be knowing, please know this, that somatostatin itself has a very short duration of action, that is just 2 to 3 minutes of T-half. Okay, so please know this. Now next coming, it has an adjuvant value in diabetic ketoacidosis. Why? Because we have already right now discussed that it is inhibiting almost everything. So it will also inhibit glucagon secretions, so that will be better for diabetic patient. It will inhibit growth hormone, that will decrease the diabetogenic potential of growth hormone. So it has an adjuvant value in diabetic ketoacidosis. There has a limited use in acromegaly. Why limited? Because we have already discussed acromegaly is kind of a chronic condition which needs a long treatment, but it has a very short duration of action of just 2 to 3 minutes of T-half. So which is the preferred path we should take for pituitary adenomas is the surgical removal rather than giving them somatostatin. Because somatostatin will act for a very short time, right? So it's better to just surgically remove pituitary adenomas. Now coming to a second antagonist or second inhibitor of growth hormone is octreotide. Octreotide, please, this is important, this number, it's 40 times more potent than somatostatin. One of the reasons why it is preferred for controlling esophageal variceal bleeding that we were talking, that octreotide is preferred. It's 40 times more potent. So a low dose is required to stop the bleeding as compared to somatostatin. So we will prefer octreotide. Also octreotide is longer acting. Its T-half is 90 minutes while the T-half of somatostatin was just 2 to 3 minutes. So obviously what should we prefer? It's longer acting, it's 40 times more potent. So for controlling esophageal variceal bleeding, octreotide is much preferred than somatostatin. Okay, it will also control diarrhea. Why? Because it decreases hormones enhancing intestinal mucosal secretion. Right now we already discussed that they will decrease GI mucosal secretions, right? Now what can be the adverse effects? Now as they are affecting GI system, we know there will be abdominal pain, dyspepsia, nausea, vomiting. One important thing is, because as we know somatostatin was causing constriction of hepatic vessels, splanchnic vessels. So in octreotide there can be constriction of bile duct. So sometimes there can be biliary stasis, and when the bile is just standing in one position, there is biliary stasis, there is often formation of gallstones. So this is a bigger risk and major adverse effect that you need to keep it in your mind, that there can be gallstones due to octreotide, right? Third, we come to lanreotide. It's also a long-acting analog of somatostatin compared to T-half of 2 to 3 minutes, and it's given IM. It is given intramuscularly and it acts for 10 to 15 days. Now it's acting for much of long time, so it will definitely be preferred for pharmacotherapy of acromegaly. We have discussed why we were not preferring, why there was a limited use of somatostatin in acromegaly, because it had a short duration of action. It is acting for 10 to 15 days, so that's why it is preferred for acromegaly. Lastly, we have pegvisomant. Now pegvisomant is not just an inhibitor, but it's a complete antagonist. It will bind to growth hormone receptor. None of the others were binding to growth hormone receptors. It was just affecting its secretion. But it binds to growth hormone receptors and it acts as an antagonist. What does this mean? It does has affinity for growth hormone receptor. There is affinity is positive as I've written, but intrinsic activity is zero. You must know general pharmacology to understand this, that antagonist does not have an intrinsic activity of -1. They do not produce an opposite effect, but they just stop the positive effect. It will just bind to growth hormone receptor and will not let growth hormone act. So ultimately acting as a negative part, but it itself has no activity. So it's acting as an antagonist and it has an intrinsic activity of zero, which can definitely be a question for MCQs. What is the intrinsic activity of pegvisomant? Right. Also, it does not trigger signal transduction. That is what we are talking about, right? It just binds. It does not cause any positive effect, does not cause any negative effect due to its binding. It does not have intrinsic activity. And because it binds to growth hormone receptors and it acts as an antagonist, it can be used for acromegaly when there are small pituitary adenomas. So that was all, guys, what we discussed from the starting. Firstly just the general introduction of anterior pituitary hormones, then going through physiological functions of growth hormone, how it produces its effects, how it's regulated, what are the pathologies, how it can be used, and analogs can be used, what are their adverse effects, how the inhibitors can be used, and what are their adverse effects. And these are the references that are used. So if you need any help or you need any other video on any other topic, please be sure to comment it down in the comment section. And if you liked how I taught, please like the video, subscribe to the channel and push the bell notifications on. Thank you for patiently listening to me.